Well, hello, everyone. Welcome back to another Women's Health webinar series. And this is part one of our diagnosis series. And we're going to start with a very common endocrine disorder that affects women of reproductive age, and it is PCOS. And my name is Zoom Heaton, and I'm the Women's Health Clinical Liaison. So we're going to go over what PCOS is. We're going to look at some potential causes, the pathophysiology, the clinical features, the signs and symptoms, the diagnosis, the associated health problems, and treatment options that are available, like the conventional therapies, the functional medicine approach, and some nutritional interventions. So, what is PCOS? It stands for polycystic ovary syndrome. And the formal definition says that it's a heterogeneous disorder that is defined by a combination of signs and symptoms of androgen excess and ovarian dysfunction with the clinical manifestations of oligomenorrhea, subfertility, hirsutism, and acne. So basically, it's a metabolic disorder with hormonal imbalances, with the main hormone disruption being higher than normal levels of androgen in women of reproductive age. It is the most common form of hormonal imbalance. So, some other names of PCOS include functional ovarian hyperandrogenism, ovarian hypertrichosis, sclerosistic ovary syndrome, and Stein-Leventhal syndrome. I think PCOS is so much easier to say. PCOS is a very complicated hormonal disorder, and it affects 10 to 15% of women worldwide, and it accounts for nearly 10% of women in the US, and it accounts for 75% of women with amenorrhea. It is estimated that 50 to 70% of women with PCOS have insulin resistance, and it accounts for 85% of women with androgen excess and hirsutism, or inappropriate hair growth. Okay, so let's go over the evolution of the diagnosis of PCOS. And it started in 1721 when an Italian scientist, Antonio Vallisneri, he actually described the anatomical features. He described a married, infertile woman with shiny ovaries with a white surface in the size of pigeon eggs. And then in 1844, Charot and Rokitansky linked the anatomical features with dysfunctional uterine bleeding. But it wasn't until 1935 that Stein and Leventhal actually linked the anatomical features with the clustering of amenorrhea, hirsutism, and polycystic sclerosistic ovaries. And then in 2004, the criteria for diagnosis came about after experts had convened at a conference in Rotterdam in the Netherlands. So the Rotterdam criteria came about in 2004. There are four types of PCOS, and insulin-resistant PCOS is the most common. There's the inflammatory-based PCOS, where inflammation plays a key role in this particular type of PCOS. And of course, chronic inflammation in the body can disrupt hormone production and cause irregular periods, weight gain, and other PCOS symptoms. So it's often associated with other inflammatory conditions like Hashimoto's thyroiditis. Post-birth control related PCOS, that is pretty much when women go off the birth control pill and they don't ovulate and they may not cycle, and their cycles are irregular. And by going off the pill, it has affected their testosterone and DHEA, causing them to have symptoms like hair loss and acne. And then there's the adrenal-related PCOS, where the adrenal glands can produce testosterone and DHEA, causing elevated testosterone symptoms. And also when you're under a lot of stress and just producing a whole lot of cortisol or adrenaline, it's possible that it'll just cause your menstrual cycle to shift and become irregular. So you can have the appearance of PCOS, but in the research, by far, the most common is the insulin-resistant PCOS. Okay, so let's look at some potential causes. As far as PCOS is concerned, the underlying cause is unknown. There are predisposing factors. There may be a genetic involvement, and of course, lifestyle and environmental factors play a role in the pathophysiology. So, what are some disposing factors? We've got family history, high androgen levels, and that's your testosterone and DHEA, your insulin resistance, obesity. And of course, obesity leads to increased insulin levels and increased IGF-1 activity and can lead to an increase in androgen production by the ovaries, leading to, of course, chronic anovulation, and it also leads to progesterone deficiency. And with high stress, you normally see lower levels of progesterone, which contributes to more hormonal imbalances and chronic inflammation. Okay, so here is the vicious cycle that contributes to PCOS. So here we have genetic changes that lead to irregular gene expression, and then we have environmental toxicants or endocrine disruptors like bisphenol A and glycotoxins. And these endocrine disruptors actually are responsible for disrupting hormonal balance and reproduction and development. Then we have dietary factors where there is an increase in fat and carbohydrate intake with low amounts of nutrients going in. All of these factors contribute to insulin resistance. And here we have in the pancreas a higher production of insulin, or increased insulin levels directly stimulate androgen production in the ovarian theca cells. And also high insulin leads to an increased fat deposit and fat accumulation. So you'll have increased belly fat, and you'll also have accumulation of fat around your organs like your liver. And again, this all leads to insulin resistance. You also see an increase in the inflammatory markers like IL-6 and TNF alpha. And then over here, we have mental stress or any kind of stress actually leading to the trigger of the HPA axis, increasing cortisol production. And anytime that you have an increase in cortisol, it leads to insulin resistance or stimulating that visceral fat accumulation and gluconeogenesis. And with higher cortisol levels, you'll see higher insulin levels as well. So the insulin resistance cycle just continues. The genetic involvement in PCOS, 35% of women with PCOS have a mother with PCOS, and 40% of women with PCOS have a sister with the disease. The research shows a defect in the FST gene, which results in alterations in follistatin. And follistatin is an anterior pituitary glycoprotein that is thought to be integral in the control of FSH and insulin and the development of the ovaries, among other functions. What you end up with is abnormal inhibition of FSH, the inappropriate stimulation of the early follicle, and an increase in androgen and insulin production. Some more genetic involvement. The women with PCOS tend to have dysregulation of the enzyme CYP17A1, and they actually have a hyperactive 17-hydroxylation enzyme, which results in the overproduction of androgens. And there's also upregulation of other enzymes in the androgen synthesis pathway. And there's decreased sex hormone binding globulin, which is a protein that is produced by the liver that actually binds up sex steroids. And when they're low, usually you'll just have higher levels of androgens circulating that can do harm. So here I'm just showing how PCOS women tend to have higher levels of this enzyme, the CYP17A1, and this is where you're converting your 17-hydroxyprogesterone into DHEA, and then using this enzyme, you're converting androstenedione into testosterone. You're also making estradiol down here. So because this enzyme is accelerated, we're going to see higher levels of your androgens. Some lifestyle and environmental factors in PCOS. Women with PCOS tend to have higher visceral adiposity, or just fat around their middle, which usually women don't like, which contributes to insulin resistance. There's also a sedentary lifestyle, and usually they are eating the standard American diet, which is high in processed foods, high in sugars, high in fat, high in carbs. And then, of course, there's the endocrine disruptors, which we've kind of gone over earlier, and they tend to alter hormones, causing anovulation, creating insulin resistance and hyperandrogenemia. So we have heavy metals, as well as the phthalates and bisphenol A. Okay, now let's go into pathophysiology. But let's get started with a quick review of the normal menstrual cycle. So here we have gonadotropin releasing hormone, which is released from the hypothalamus in a very normal pulsatile fashion, traveling in the blood to the cells of the anterior pituitary, stimulating the release of FSH and LH, which travel to the ovary to act on the thecal and the granulosa cells of the follicle, causing them to work together to produce estrogen prior to ovulation in the follicular phase, and mostly progesterone after ovulation during the luteal phase. Now, during the follicular phase, days 1 to 14 of the normal menstrual cycle, there is a higher amount of FSH that stimulates the follicle development in the ovary. Now, the mature follicle produces increasing estrogen, which helps to stimulate an LH surge. And the surge around day 14 stimulates the release of an egg from a mature follicle, and this is ovulation. And the ruptured follicle then, of course, turns into the corpus luteum, which produces higher amounts of progesterone during the luteal phase, which is day 14 to 28. Unfortunately, in PCOS, we see higher levels of LH, and this prevents normal follicle development, and there is no surge in LH mid-cycle to stimulate ovulation. And here LH stimulates androgen production in the ovary, which can also be converted to estrogen through aromatase activity. And of course, without ovulation, there is no corpus luteum producing higher amounts of progesterone. The hyperandrogenism and anovulation that accompanies PCOS may be caused by abnormalities in 4 endocrinologically active compartments. You've got the hypothalamus and pituitary, the ovaries, the adrenal glands, and the periphery, which is fat. So insulin-resistant PCOS, 70% of women with PCOS have higher insulin. Up to 64% of women with PCOS are insulin resistant. 70 to 80% of women with PCOS are overweight or obese. 20 to 30% are not. So that is considered lean PCOS. Women that are overweight and women that are not, who have PCOS, both have higher rates of insulin resistance and hyperinsulinemia than controls. Women with insulin-resistant PCOS are more at risk for long-term health outcomes, and this is why we can't treat this as a short-term condition, like just balancing hormones. We have to think long-term, because the effects of insulin on her body will increase her risk for type 2 diabetes, gestational diabetes, increase for high blood pressure, high triglycerides, stroke, anxiety, sleep apnea, and depression. So how does insulin cause PCOS? So let's begin with a review of the anatomy of ovarian cells. Okay, so on your ovaries are follicles, and on each individual follicle are cells. So on the outside of the follicles are the theca cells, and they make your androgens like testosterone and DHEA. And then inside the cell, you will see the granulosa cells. And estrogen, estradiol in particular, is predominantly made here. And so the thicker cells here make androgens, they diffuse over to the granulosa cells, and they make estrogen. These are the cells that make your hormones in the ovaries. And both the theca and the granulosa cells have insulin receptors, and they're very receptive to insulin. So if you have chronic high insulin, you can increase androgen production from the cells and increase estradiol production in the granulosa cells. Since, of course, androgens like testosterone can diffuse into the granulosa cells and turn into estrogen. So the more testosterone you make, more likely you'll have higher estradiol levels. This can happen. Not always, but it can happen. And unfortunately, chronic high insulin can have negative effects on the developmental stage of the oocyte inside the follicle, so it affects your hormone production, which in turn can affect fertility. Okay, so here I just want to show you that hormones are made in the mitochondria and in the endoplasmic reticulum. So LH binds to the cell, and in the mitochondria, cholesterol is converted into pregnenolone, and this gets sped up by insulin, and then it leaves and goes to the endoplasmic reticulum to form testosterone, androstenedione, and then estradiol. So this is important to note because we're going to be discussing the oxidative stress inside the cell, inside the mitochondria and endoplasmic reticulum, that plays a huge part in inflammatory PCOS. Okay, so oxidative stress plays a really big part in the pathophysiology of PCOS because it can impact various cellular compartments like the mitochondria and the endoplasmic reticulum. Oxidative stress is actually a very normal part of creating hormones, but when you're making like a lot of hormones like testosterone, or you're exposed to a lot of toxins or chemicals, which is a lot of inflammation, you can make a lot of oxidative stress. And when this happens, it promotes the death of granulosa cells. So the hormone production and ovulation really can't occur. Granulosa cells make estrogen. And in PCOS, all of this oxidative stress, estrogen can be high or low. And in order to ovulate, you have to release the egg. And your theca and granulosa cells can turn into cells that make progesterone, but these cells are damaged and are killed through what is called apoptosis, and ovulation can occur. So the more insulin, the more inflammation, the more testosterone, the more stress in the ovary, the more risk she has for having low progesterone and not being able to ovulate. And this is very important, especially important in women who are trying to get pregnant, or they're struggling with PMS symptoms right before their period, fibroids, endometriosis. Here, your hormones are all out of balance as a result of this oxidative stress. And of course, the symptoms show up like hair loss or acne or weight gain. So induced oxidative stress in the endoplasmic reticulum can further exacerbate insulin resistance, inflammation, and hormonal imbalances that are commonly seen in women with PCOS. Okay, the insulin factor in PCOS. Insulin is a stimulator at many stages of the hormone production. It stimulates pregnenolone production from cholesterol. It stimulates the production of DHEA from pregnenolone. It also stimulates the production of DHEA to androstenedione to testosterone. Insulin also decreases SHBG, increasing circulating levels of testosterone. It also works with LH to increase androgen production in the ovarian theca cells. So essentially, insulin increases androgen production, in turn increasing inflammation. Here, I just wanted to show how insulin affects all of these cellular compartments: your hypothalamus, your ovaries, the liver, the adrenal glands, and fat tissue. So chronic high insulin can do damage to so many parts of the body. So how insulin resistance affects the menstrual cycle. Elevated insulin leads to an altered hypothalamic function. So FSH and LH are not secreted properly, and more LH is secreted, which increases the activity of enzymes in the ovary responsible for producing androgen, and higher insulin levels decrease production of sex hormone binding globulin as well in the liver. And SHBG, of course, is that protein that binds to sex hormones to inactivate them. So the lower levels of SHBG increase the amount of free testosterone in the system, which is responsible for the signs and symptoms of androgen dominance, abnormal hair growth, and acne. And of course, elevated androgens in women can in turn also increase insulin levels. This is a vicious cycle that creates inflammation and an altered functioning of the hypothalamic, pituitary, and ovarian system. Okay, now we go into clinical features. So this is your PCOS clinical picture: irregular periods, menstrual and pelvic pain, mood swings, weight gain or difficulty in losing weight, enlarged cysts in the ovaries, hirsutism, which is inappropriate hair growth, decreased follicle, decreased FSH, acne, darkening of the skin, increased levels of LH, and difficulty becoming pregnant. Androgen excess seems to be the hallmark of PCOS, and there's a lot of skin issues that PCOS patients go through. They have thinning scalp hair or alopecia, hirsutism, which is inappropriate hair growth. It's present in 70% of the women in the US with PCOS. They have oily skin, acne, and usually cystic acne that occurs right down here below the jawline here, and it's painful. And that's seen in 30% of patients with PCOS. Seborrhea, and then skin tags, the acrocordyns. Here you go. Sleep apnea, pelvic pain, depression, and tension also accompany PCOS. And with ovulatory dysfunction, we see irregular or absent menstrual cycles, miscarriages, infertility, which affects 75% of the women who are obese with PCOS. So with insulin resistance, we see obesity or the inability to lose weight. And this is abnormal weight gain, usually seen around the waist as opposed to overall weight gain. The high hip to waist ratio greater than 0.85, BMI of greater than 30. And we also have the acanthosis nigricans, and they have a lot of skin problems like acne and oily skin, dandruff, or dark skin patches on the neck here, the groin, the underarm, or skin folds. And of course, they also have skin tags, possibly in the armpits or the neck area. And women with PCOS tend to have higher risk for seizures. Women with epilepsy have 10 to 26% higher risk for PCOS. 40% of the women treated with valproate for epilepsy have polycystic ovaries, and 17% have high testosterone levels but don't have polycystic ovaries. Other clinical features, they often have high blood pressure, and also their lipid profile is off, where they have elevated levels of triglycerides and LDL and total cholesterol. Okay, so how do we diagnose PCOS? So we have the Rotterdam criteria, and you have to have 2 out of 3 of the criteria present. First one, you've got polycystic ovaries as seen by ultrasound, but having just one cyst on an ultrasound does not count. So there must be many multiple size or many cysts that are the same size. And in PCOS, the follicles grow and then they stop, and another one will grow and then it stops. And it's often referred to as the string of pearls because they're all about the same size. And these are just failed follicles that form, and there's several of them, and it just looks like a string of pearls. Okay, number 2, hyperandrogenic symptoms and elevated androgens on testing. So high levels of testosterone, DHEA or DHT, which is dihydrotestosterone, which is a more potent form of testosterone. Upon testing with symptoms like male pattern hair loss in women, cystic acne on the jaw, inappropriate hair growth in places she doesn't want, which again is hirsutism, and mood changes where She may be more irritated or angry. And number 3, ovulatory dysfunction. So she just struggles to ovulate. Her cycles are irregular and she has no cycles, amenorrhea, and her progesterone levels are pretty low. So I just wanted to include some abnormal lab values that are associated with PCOS, some parameters to look over when you're working up a PCOS patient. And be aware that not all of these individuals with PCOS will have the every abnormal lab value. Diagnosis is typically based on a combination of symptoms, physical exam, and of course, lab values. Testing hormone levels is important to look for those high androgens like your testosterone, your DHEA, your DHEAS, androstenedione, because these androgens, these high androgens, contribute to the unwanted side effects. Then you've got high estrone levels. So excess androgens can be converted to estrone in the periphery or fat. Elevated insulin levels, of course, contributes to insulin resistance. Your oral glucose tolerance test is also important for insulin resistance. Your LH-FSH ratio, if that's elevated and greater than 2-to-1, that's usually seen in PCOS. This imbalance can contribute to irregular periods and difficulty with ovulation. Decreased SHBG levels, you'll see cysts upon ultrasound, C-reactive protein, which is an inflammatory marker, and possibly abnormal lipid profile. Now let's look at associated health problems in PCOS. So women with PCOS may have higher cardiovascular risk than weight-matched controls with normal ovarian function. So they have increased cardiovascular risk factors like obesity, hyperandrogenism, hyperlipidemia, hyperinsulinemia, and an increased risk of atherosclerosis, and they have elevated plasminogen activator inhibitor, resulting, of course, in impaired fibrinolysis. So they have more clots. They have 4 times increased risk for hypertension, 7-fold increased risk for acute MI. And patients with PCOS are also 7 times more likely to develop diabetes, even higher if obese. Up to 64% of women with PCOS are insulin resistant. And often we see thyroid dysfunction. Studies showed that teenage girls with PCOS treated for hypothyroidism had a resolution of ovarian cysts and showed a decrease in LH levels. And a study showed 3 times higher prevalence of autoimmune thyroiditis in women with PCOS versus controls without PCOS. And subclinical hypothyroidism might be manifested as PCOS. We see gout, infertility, sleep apnea, endometrial cancer, and other women-related cancers. There's a 5-fold increased risk of endometrial cancer, and there is increased risk of ovarian, breast, and cervical cancers. And here are your citations. More associated health risks. We just went through the CV risks, and this is just defined for you to look at the risk factors and abnormal lipid profiles. And with type 2, there's usually a strong family history, BMI of greater than 30, and they're usually over age 40. And with endometrial cancer, they have severe oligo and amenorrhea in premenopausal levels of estrogen, can lead to endometrial hyperplasia and carcinoma. So women with PCOS intervals between menstruation of more than 3 months may be associated with endometrial hyperplasia. So here, the major reason PCOS increases the risk of endometrial cancer is that prolonged exposure of the endometrium to unopposed estrogen caused by anovulation. And here is a nice table showing the short-term and long-term associated health problems for you. Okay, treatment. Treatment is individualized and determined by patient goals and severity of symptoms, and there is no universal treatment for PCOS. So treatment is aimed at relieving symptoms and preventing adverse long-term effects. The symptoms that are targeted include amenorrhea, hirsutism and acne, your infertility. Also, treatment aims to lower insulin levels weight reduction, and of course to prevent endometrial hyperplasia and endometrial cancer. So conventional treatment includes the restoration of ovulation and menstruation. So conventionally, combined oral contraceptive pills are used mainly to suppress gonadotropin release, reduce androgen levels, and induce regular menstrual cycles. Another option are the cyclic progestins, where the combined oral contraceptive pills are not indicated. You have the synthetic progestins, levonorgestrel, and drospirenone are some examples. You also have IUDs, progestin-only options like Mirena, Liletta, Kyleena. And of course, you also have the copper option, which is non-hormonal. For insulin resistance and hyperinsulinemia, we have the anti-diabetes drugs like the metformin, which is a biguanide. It does improve peripheral insulin sensitivity and it reduces hepatic glucose production. It increases target tissue sensitivity to insulin, reduces androgen levels, aids in spontaneous ovulation. It facilitates weight loss. And the dose is usually 500 to 2,000 milligrams a day or in divided doses. Also, we have another class of diabetic drugs, the TZDs, thiazolidinediones, and they suppress hepatic gluconeogenesis and improves the entry of glucose into muscle and fat. Treatment of infertility, we use ovulation-inducing drugs like clomiphene citrate. There's the combination with clomiphene and metformin. There's tamoxifen. You can also have gonadotropin alone or with HCG. And there's assisted reproductive technology, which really refers to the wide spectrum of advanced medical procedures to help individuals and couples with infertility. So you have IVF, assisted hatching. There's also egg donation and surrogacy. For the treatment of hirsutism, the combination oral contraceptive pills are often used to lower those androgen levels, but synthetic estrogens do increase SHBG. Anti-androgens, spironolactone and flutamine are used. And then, of course, the 5-alpha reductase inhibitors like finasteride. So finasteride inhibits the expression of type 2 enzyme 5-alpha reductase. And this enzyme, of course, regulates the production of dihydrotestosterone, which has been shown to have a harmful effect on hair follicles. Then we have, for the treatment of acne, again, combined oral contraceptive pills, topical retinoids, systemic and topical antibiotics, topical benzoyl peroxide, and isotretinoin, which is Accutane. There's also surgical management where ovarian wedge resection is used to induce ovulation. There's also ovarian drilling, and that's to reduce the amount of ovarian stroma, thus decreasing androgen producing cells. So you have bariatric surgery, reducing weight, in turn reducing insulin resistance, androgen production, adipose compartment decreasing aromatization, and of course it also improves ovulation. So while conventional medicine aims to treat symptoms, the functional medicine approach is to look at root causes of disease. So here with PCOS, looking at root causes, we need to look at gut dysbiosis. So with gut dysbiosis, here we're looking at how the microbiome plays a big role in hormone balance and understanding how our gut bacteria can affect our hormones, insulin, and symptoms. And there are studies showing the association between changes in the gut microbiome and the metabolic and clinical parameters of PCOS, and have proposed that dysbiosis of the gut microbiota may be a potential pathogenetic factor in the development of PCOS. We also have environmental endocrine disruptors like plastics, pesticides, heavy metals. And then we also have the lifestyle modification where diet is so important. We have to eliminate processed foods, foods with high glycemic index, and we have to increase our fiber. Since higher fiber intake, the soluble fiber, non-starch polysaccharides, and resistant starches can be very helpful because they may be due to the connection with the gut flora, may also be due to the impact that it has on insulin levels and blood sugar. So we know that fiber intake can significantly affect blood sugar and glucose sensitivity in some people. So other lifestyle modifications, weight loss, even a small amount of weight loss, like 5% of your initial weight, can actually normalize menstrual cycles, and ovulation could occur. And moderate exercise does reduce waist to hip ratio. It decreases the risk for metabolic syndrome and insulin resistance, balances hormones, and increases the psychological well-being as well. So reducing stress is a must. Cortisol, or stress hormone, stimulates the release of glucose, fats, and amino acids for the production of energy in the body. So stress causes cortisol, glucose, and insulin levels in the body to rise, and an increase in cortisol decreases progesterone production and its activity, since cortisol competes with progesterone for common receptors, and elevated cortisol levels can exacerbate the symptoms of PCOS. And with stress management, there's so many ways to do that. Meditation is so good for the mind, the body, the soul. You've got exercises like yoga and Tai Chi. A lot of times I tell my women to take at least an hour a day, every day, whether you want to break it up into 15-minute increments throughout the day, or to take the whole hour at any time that suits you during the day or night, and just literally decompress. No phone, no computers, no family members around. I mean, you literally kind of just be on your own. And if you want to, just turn off the lights, relax, and just allow your mind to go free and your body to relax. Well, those adrenal glands need that decompression time for them to start healing. Here are some citations. Research has found that PCOS is an inflammatory condition, and there is a lot of research now suggesting that dysbiosis within the digestive tract has a significant role to play in PCOS, which we've gone through earlier. Here are some citations. So, with the functional approach, we want to balance the gut microbiome. And from the dietary perspective, we want to eat low glycemic index foods like legumes, your nuts, your seeds, your unrefined carbohydrates, your steel-cut oats, your brown rice, your whole grain bread. But you have to be careful with whole grain bread sometimes as well. Gluten, if gluten is an issue. So we have to be careful with that. And these low glycemic index diets offer potential to reduce insulin resistance, decrease stress, of course, take the symbiotic supplements with like the pre and probiotics. And I like the combination of prebiotics being in with the probiotic, which we'll go over, and also healthy exercise and nutritional support. So here are some nutritional interventions. So the gut plays an important role in controlling inflammation, balancing hormones, and promoting overall health. So, if inflammation is the key driver of insulin resistance and insulin resistance worsens inflammation, then a probiotic supplement is one tool that we can use to optimize gut health in the PCOS patient to lower inflammation and disrupt this vicious cycle. And in a randomized double-blind control study, it confirmed that probiotic supplementation with these strains, the Lactobacillus acidophilus, Lactobacillus casei, and Bifidobacterium bifidum, those strains significantly increased serum levels of SHBG, reduced total serum testosterone levels, reduced modified Pheromone Galway, MFG scores, improved chronic inflammatory states because it decreased your inflammatory markers like C-reactive protein and MDA, malondialdehyde, and there were no adverse effects of probiotic supplementation seen. And of course, prebiotics are important because they are actually food sources for your microbiome, but it helps your probiotics kind of stay in the gut longer because it's actually food for those probiotics. So you've got chicory root, inulins, Jerusalem artichoke, partially hydrolyzed guar gum. So homocysteine is commonly elevated in women with PCOS. So lowering homocysteine levels can reduce risk factors for heart disease and Alzheimer's and reproductive symptoms. And B vitamins are essential. You've got your B2, which aids in the conversion of dietary fats, protein, and carbohydrates into energy. You've got B3 that aids in maintaining normal blood sugar levels. B5 assists in weight loss. B6 helps to maintain the hormonal balance and fertility. It's needed for proper absorption of zinc in the intestines. Then you've got B9 and 12, which helps to reduce inflammation by breaking down homocysteine. So you want to choose a B complex vitamin that contains the methylated forms. And if you want to be thorough, you can do an MTHFR test, which is the genetic SNP, where a person cannot break down their homocysteine well, and they need the methylated versions of folic acid and B12 to be able to break down that amino acid. B2, B3, and B6 are all essential for normal thyroid function and metabolism, which of course helps with losing weight. So a really good B complex would really help here. Vitamin D, it is a prohormone. It's involved in hormonal and immune balance, shown to improve insulin resistance. It lowers inflammation. It is shown to improve menstrual regularity after 3 months of use, shown to improve fertility and pregnancy rates during assisted reproduction therapy. It improves mood and depression also in women with or without PCOS. So up to 85% of women with PCOS have a vitamin D deficiency, and lower vitamin D levels are significantly associated with worsening insulin resistance in PCOS, independent of your weight, ethnicity, or season of the year. A study found that supplementation with 1,500 milligrams of calcium daily and 50,000 international units of D2 on a weekly basis normalize menstrual cycles or fertility in all women studied with PCOS-related menstrual irregularities within 3 months of treatment. And the dose is personalized based on lab results. Levels need to be at 55 at a minimum. Optimal levels of vitamin D are between 60 and 80. Give with K2 for bones, because of course, when you give it with K2, it kind of directs calcium to your bones where it can be used and stored versus in your arteries. And take with food because it is a lipid soluble vitamin. Magnesium, it's difficult to really obtain adequate magnesium through diet alone, and it plays such an important role in improving the functions of insulin, leptin, thyroid hormones. It's essential in the production of estrogens and progesterone. It can also be very calming to the nervous system. So magnesium is just so critical for 300 different enzymatic activity in the body as well. And the dose is 200 to 400 milligrams daily in the evening based on bowel tolerance. Zinc. It appears that women with PCOS may have lower levels of zinc than women without it. And because of this, women with PCOS may see impaired hormonal, lipid, and glucose metabolism, in addition to increased concentrations of oxidative stress biomarkers. This is bad. So low levels of zinc means you're at risk for insulin resistance, oxidative stress, and impaired hormonal metabolization. It is an essential mineral, and it is responsible for the regulation of cell growth, hormone release, reproduction, immunological response. The best absorbed forms of zinc are the picolinate, acetate, or glycerate, and dosing is 20 to 50 milligrams daily, and you can take it with the multivitamin that contains copper so that you can keep that zinc to copper ratio in balance, which is usually 8 units of zinc to 1 unit of copper, and the acceptable range is 4 to 12. And studies have also shown that zinc can help fight acne, reduce inflammation, and prevent hair loss, as well as protect against chronic conditions like heart disease and diabetes. So it's so critical to have zinc on board. This is a randomized control study of the effects of zinc supplementation on reproductive symptom disorders like PCOS, and it was concluded that zinc has a positive effect on insulin resistance and lipid balance. And as an added bonus, when dosed before and during each menstrual cycle, it can also reduce the intensity of pain associated with menstruation. So you're not suffering so much from PCOS pain. Here are your citations. So other nutrients like resveratrol and apigenin, they both slow down or inhibit that enzyme CYP17, decreasing androgen production like testosterone and DHEA, and with apigenin, androstenedione as well, and even possibly with estrogen. And with resveratrol, the dose is 800 to 1500 milligrams per day. Apigenin, which is a flavonoid, it inhibits the inflammatory cytokines also, IL-6 and TNF-alpha. So it's almost like an anti-inflammatory. So it's an anti-inflammatory as well. The dose is 50 to 100 milligrams. Also, just to keep in mind, normal dosing of resveratrol is 250 to 500 milligrams, but higher dosing is necessary in a PCOS patient. And then you have inositol. You have the D-chiroinositol and the myoinositol. They're isomers of inositol, and they're important cellular second messenger for insulin. And they both showed equal improvement in acne scores, menstrual regularity, and insulin resistance. And the D-chiro showed better decreases in androgens. And the dose is 1,200 milligrams daily of either NAC or N-acetylcysteine. Studies show that using NAC in combination with clomiphene citrate increased ovulation and pregnancy rates in women with infertility that had PCOS that could not conceive with the use of clomiphene alone. And of course, studies have also shown improvement in glucose and insulin. It's the precursor to glutathione, which is one of the most potent detoxifiers in the body. And the dose is 1.5 to 3 grams a day. Adaptogenic herbs are so useful. It tames the HPA axis. It helps to improve that stress response. So my favorite is Relora, and that is the philodendron and magnolia bark extracts. There's also ginseng, rhodiola, ashwagandha, holy basil, astragalus root, licorice root. There's so many of them. And it really helps to tame that very stressed out HPA axis. Once it helps that stress response be more normal, the patient starts to feel better. Then you have chasteberry, which is Vitex agnus castus or monk's pepper or Vitex. It lowers estrogen progesterone ratio. It also indirectly increases progesterone. The dose is 200 milligrams to 1,000 milligrams of standardized extract, and take it in the morning every day. And it's often used in the luteal phase of the menstrual cycle to help support progesterone production. Berberine, one of my absolute favorite herbs. It lowers fasting blood sugar. It improves insulin resistance in the theca cells. It also improves menstrual patterns in the PCOS infertile women, improves lipid profile by lowering cholesterol. It also helps with weight loss. And the dose is 200 milligrams twice a day, but sometimes I will actually go up depending on the severity of the insulin resistance and depending on the tolerance level of the patient. And berberine is actually hailed comparable to the conventional drug metformin or glucophage. And that drug has been amazing, actually, in the world of diabetes. It's used widely to lower blood sugar, to help with insulin sensitivity. And I have patients who actually improved on their lipid profile once they were on it. Okay, so let's talk about TUDCA. It is tauroursodeoxycholic acid. It is a bile acid that is naturally found in the body, and as a supplement, it's very helpful for the gallbladder and bile formation in the liver. It assists detoxification and digestion, and studies have shown that TUDCA helps to reduce oxidative stress in the endoplasmic reticulum, which of course helps to reduce stress in the ovaries. Studies carried out with obese, overfed mice showed that TUDCA supported healthy blood sugar levels and supported insulin sensitivity. And it's believed to increase energy burned at the cellular level. which potentially affects how the body regulates insulin. And high blood sugar levels due to poor insulin regulation can actually damage endothelial cells and cause oxidative damage. So, under this oxidative stress, TUDCA has been found to help support that cellular health in the presence of too much glucose. And there isn't a standardized dose for TUDCA, but research on TUDCA has shown that it is effective in adults using doses between 250 to 1500 milligrams. And when it's more than 1500 milligrams daily, some people have reported some diarrhea with it. And aside from that complication, there's really no other reported side effects for TUDCA. It's really like Windex for your liver. Okay, on to white peony, the beautiful flower. It has shown to be effective in the treatment of PCOS by increasing progesterone. It reduces too much testosterone. It regulates LH to FSH ratios. It increases ovulation and conception. It regulates estrogen. And the dose is 4.5 to 9 mLs of a 1 to 2 dried plant extract. And last but not least, nettle root or Urtica dioica. It binds to and increases SHBG, decreasing the amount of testosterone available for the body to use. And the nettle leaf does not work, so you have to find the nettle root. And the dosing on that is 300 milligrams twice a day. So just a quick recap. PCOS is a complex endocrine and metabolic disorder that's very common in women of reproductive age that involves sex hormone dysregulation, insulin resistance, and inflammation. And the etiology is different for everyone. So we have to kind of look at what the driving forces are that are creating their PCOS diagnosis or symptoms and take it from there. And you want to target insulin resistance and inflammation, and also the hormonal imbalances that lead to anovulation and infertility problems. And medications are an option, but modifying lifestyle. We have to look at habit changes, like better, cleaner diet options, moderate exercise, more sleep, hydrating more, reducing stress, looking at the chemicals that we use on a daily basis, like shampoo, hair products, hygiene products, cosmetics, plastic water bottles, pesticides in foods and skincare products. These are endocrine disruptors that really are very ubiquitous. And we have to pay attention to all of that. It's getting into our bodies and doing harm to our organ systems. And also provide supportive supplements, because supplements can help fuel the mitochondria to help correct certain imbalances by reducing inflammation. So lifestyle changes and giving supportive supplements can be a really good start as you're working on balancing other organ systems. Well, thank you so much for joining us today, and please connect with us. We are a national network of 503A and 503B compounding pharmacies, providing innovative and quality pharmacy preparations and services through industry-best patient care and solutions for customers and healthcare professionals. We're here to help you and your patients with programs like ConsultRx, which is a nationwide VIP service for clinical consulting, with our functional medicine and anti-aging board certified team of clinical pharmacists and practitioners bringing a combined 50 plus years of experience to provide the highest level of service possible. Please join us for another informative webinar coming soon.